Okay, thank you for attempting to do that quickly. So I'm really, like I was saying earlier, I think one of the things about this meeting is trying to bring together lots of different kinds of practitioners who are seeing lots of different types of HLH patients. And so I'm really pleased that we've now got some adult and adolescent transplanters and haematologists talking to us. So first is Ben Carpenter, who's a transplanter from UCLH. And so he's going to talk about HLH predominantly in the adolescent population.
Good afternoon. It's good to be able to come and speak to you today. I'm going to borrow a little bit from our adult practice as well with our rheumatology and adult haematology colleagues, just because I think if I talk to you just about adolescent HLH, it would be even shorter than the talk's going to be in terms of the data I can call upon. But what I want to do is tell you a little bit about our unit, how it ties together, present a couple of cases that I think exemplifies an extreme of the different types of cases that we see. Talk about the MDT that our team's involved with. I think you've heard a little bit about already, and then to go on to talk a little bit potentially about the indications and the setup for adult transplant for HLH. So in terms of a lot of the interfaces, there can be quite a culture clash in terms of how these problems are addressed, and you can put paediatrics and adults there, you can put rheumatology and haematology and other specialities, and we're not always speaking the same language, we're not always approaching things in the same way, and I think that's a weakness. That's why we're not entirely sure how to approach all of these patients at the current time, but also I think it's a strength because we call upon different experiences. The rheumatologists are educating us about anakinra, and it's exciting to be able to bring in more weapons to try and treat our patients. So our unit looks after, so the adolescent side at UCLH looks after patients between 13 and 20 years. We have a young adult unit as well from 20 to 25 years, and then it goes on into that adult patient as a patient population as a whole. The adult team look after the 20-year plus. We have on the TYA side dedicated inpatient beds. We have psychologists. We're very well supported. We've got nice facilities with pool tables and all the very important things you need to have, but also outpatient ambulatory care as well. And we also work on the other side in continuity with the team at Great Ormond Street from a malignancy point of view, and also from particularly primary immunodeficiency point of view on the transplant side. So the idea is that hopefully this is a seamless virtual unit from GOSH through to us and then on to the adult teams. We together, Jessica Manson has been really driving this forward, has been trying to put HLH MDT together. We met together and went through a couple of cases yesterday evening. We're trying to meet at least once a month, mirroring I think what you guys have been doing at GOSH, and I think probably you guys also do at the Hammersmith. And so we've got quite a lot of good engagement, I think, and we got virologists coming along last night to talk through the cases, which I think is good, alongside intensivists, infectious diseases doctors and rheumatologists and haematologists. And so out of this, a project to look at cases has come about at the hyperferritinemia case review that Jessica and Chris from the haematology side have helped put patients in together.
People started and we nipped.
And also that's all part of the ongoing engagement. And so also that's looking at data from the Royal Free and from UCLH. So I'll come on to that in a minute. As I said, I wanted to just go through a couple of cases to just show examples of really the sort of type of presentations that we see. The first one was a 15-year-old chap who presented with 2 weeks lethargy, diarrhea and fevers to his local hospital. He came in with an acute kidney injury. He had a lot of edema, very fluid overloaded, effusions, ascites. He was pretty unwell, hypertensive. He's needing fluid boluses, but he didn't need ionotropes. He had a coagulopathy, had a big spleen, had a slightly low platelet count. The rest of his counts weren't too bad. But when he came across to us, it was with the question, did he have a hematological malignancy or could this be HLH? He had a PET scan. We do like a PET scan, and so he had small volume lymphadenopathy above and below diaphragm. He had a big avid spleen, but when the rest of the tests started to come back, then we started to move in the direction that we ultimately formed a diagnosis from, that he had a significant ferritin of 35,000, his triglycerides were up, The soluble CD25 didn't come back immediately, but it did come back and was raised subsequently. EBV PCR showed a good going viral load of 170,000 copies, and he had a lumbar puncture which was acellular, and there was no clear indication he had any neurological involvement, but he was, when he presented, obviously very sick. He had a bone marrow which showed clear evidence of hemophagocytosis. It was very clear cut. But also had a lymph node biopsy because we were working him up for query malignancy, and interestingly there were changes consistent with EBV infection, but also there was hemophagocytosis in the lymph node as well, so there was good tissue evidence of a HLH process. He was treated with dexamethasone and rituximab, and that's the only treatment he had from an HLH point of view, and he actually had a really rapid response to that and settled quite quickly over the following 2 weeks. His EBV cleared very quickly, actually within the first few doses of rituximab. His fluid resolved, and he was up and about, and he was out of hospital within around 2 to 3 weeks. He was on a weaning course of dexamethasone, and I think by about 8 weeks he was off dexamethasone entirely, and now he's over a year out. We've been continuing to follow him up, and there's no clear evidence of recurrence at this current time. I think one of the things to pull out of his case was actually the psychological trauma of his episode in hospital. I think there wasn't massive delays in the diagnosis. One of the things, just talking to Nicky about, we think could have a significant impact on people's outcome from that perspective. But really the fact he was well 2 weeks earlier, very sick 2 weeks later, and actually then back home a few weeks after that, I think he found that sort of very rapid course through being very unwell very hard to deal with, and he actually needed an awful lot of psychological support to get over that, and that was one of the big consequences for him. We went on, did some further testing. Perforin's CD27 expression all normal, the release assay was normal. He did go onto the Tiger panel. He had a history of nasal abnormalities which he needed surgical repair as a child, and there was some history of developmental delay. He'd seen a geneticist previously, and so we thought it would be particularly important to screen him, but we didn't find anything significant from the Tiger panel. And so, as I say, he's in watch and wait, and he's doing well. The second patient.
Did you prove it was primary EBV infection? Do you think that's important?
In terms of serologically, do we know?
You know, if you'd reactivated EBV, maybe would be more or less correct. If you consider you would get sick with a primary infection, like a really bad glandular fever for you.
Yeah, and I think that could be possible. I can't discount that still. I mean, I suppose he would have had a very bad course of glandular fever in terms of, and you know, people do get very unwell, don't they, with primary EBV infection. I think his clinical presentation was above and beyond what I'd expect with that, in terms of, you know, sort of being peri-inotropic support, I think, with EBV. And again, then I suppose you start to come into the more philosophical question of where does the beginning and end of HLH and an abnormal response to EBV infections start and stop in terms of HLH and an exaggerated EBV response.
That's what I'm saying. I'd almost be more worried if it wasn't a primary infection. He might have an underlying thing that means he's never going to really, going to become a chronic active EBV. So isn't it quite important to know whether it was?
So in terms of, he has cleared the EBV, and a year later he's shown no evidence of reactivation. So it's not that he's I suppose in another situation of primary immunodeficiency patients, he's not got a grumbling sort of even positive below the limit of quantification EBV. And so I've taken some reassurance in that. That may be right or wrong. I'm going to continue to...
Did he have IgM?
Yes, no, I believe he was. So that was my memory, yeah. So, but yeah, no, I've continued to look, and I'm going to probably continue to look for a little bit longer, but yes. So the second patient I was going to talk about is a 16-year-old chap who presented to a centre elsewhere in 2012 with pancytopenia. He had appropriate workup, and subsequently a diagnosis of HLH was made. They did find an underlying clear genetic defect of MUNC 18.2. He was given Dex, cyclosporin and IVIG up front, and he responded to that and went into a nice remission, as I understand. He then had recurrent episodes late in 2016, which again settled quite quickly with dexamethasone. And I think at that time there were some discussions about should he go to transplant or not. And it was felt because he was back in school, he was doing very well, then that was not what, in consultation with the family, they wanted to do. They didn't want to take him to transplant at that time. Unfortunately, he had further relapse. He had Dex and etoposide, but really he didn't have a good response, and so he went on to trial of biologicals. So he had anakinra, Novamine, and also ultimately Chemcap because he really wasn't responding to that. We weren't getting on top of the HLH. Actually, this treatment was given elsewhere, but when he came across to us, he had some further doses of anakinra. And overall, it looked like we were going to get as much control as was possible at that point. He had a sibling match donor, and so given the fact he was settling clinically, we felt that this was the time to either transplant or not, and that it was not survivable without a transplant. This was discussed very clearly with him and his family, and I think they were very clear that this was our only opportunity to go ahead. At the time of the transplant, he had a number of issues. He had HSV infection, he's had steroid-induced diabetes, he's quite deconditioned, he'd had a previous chest infection, also had sternotrophomonas, had lines removed, and felt that we'd cleared that. But he'd also had a relatively recent history of quite large volume GI bleeds. He'd been down to ITU, had CT angiography trying to find bleeding points, but really was quite unwell. But as I say, this was felt to be the only window of opportunity that we had. So he had an FT, fludarabine, treosulfan and Campath sibling transplant. Initially he responded quite well to that. He continued to improve, settle. He had problems with HSV in his mouth. He also became drowsy later on. And we worked with that he had an HSV encephalitis, so that was investigated with imaging and CSF, but there was no clear evidence of HSV by PCR, and so when we weaned his opiates, he actually, in fact, again improved. But really, with the foscarnet treatment he had, fluid balance became more of a problem. He had a degree of kidney injury, he developed diarrhea, and again became fluid overloaded, so he went down to ITU. The HTU for fluid management, fluid balance management. The foscarnet was held that had been given for the HSV. He did have a septic deterioration and was treated with tazocin, and his antifungals that he'd been on previously was switched to caspofungin, which again he stabilised, but unfortunately had a further septic episode, and that was complicated by a cardiac arrest, and he needed to be intubated and started on hemofiltration. Again, he seemed to plateau, his acidosis was improving, he engrafted, we thought that we were getting somewhere, it was looking like we were starting to win, his fluid balance improved really significantly, we were looking like he just needed to be on HDU, query even was he moving towards being able to be stepped down to the ward, but unfortunately he then had a further deterioration, this time from a respiratory point of view, alongside the antimicrobials that he was on. We covered for PCP, had steroids, clindamycin and primaquine, but then really he developed further more established organ failure, started having some bleeding from his ET tube, and really with discussions with his family, they felt he'd been taken as far as we were going to get, and really that that was the ceiling of what we should provide for him, and unfortunately passed away quite quickly after that. So that is obviously two quite extreme ends of the spectrum, whether or not the first patient has HLH, what the mechanism of his response. But I suppose reflecting on the second patient, one of the things in retrospect he would have wanted to do is with transplant him when he was in remission. Hindsight's obviously a wonderful thing, and that was discussed with the family. But I think that it underlines, particularly in our population and moving into the adult population, now we are able to transplant adult patients, is thinking, should we be looking for more genetic lesions in our adult population, because it's going to help inform making those decisions and making those decisions early. But really that in terms of what we'd consider the primary HLH patients, that's not really the majority of the handful of patients that we've seen over the last few years. Most of them are either driven by EBV, we believe, or by malignancy. So a handful of malignant patients that we've seen with HLH have either had Hodgkin's or anaplastic large cell lymphoma, or, as I say, EBV driven. Our approach, right or wrong, has been for the EBV patients to give them rituximab and steroids, and really, if they're not moving in the right direction, then to give them etoposide. And we haven't had to do that with any of the EBV patients so far. And if they're lymphoma-driven, steroids, rituximab as appropriate, and then etoposide. And then once they are clinically stable, give them definitive chemotherapy. And with the Hodgkin's patients, that's normally OEPA. If they've got significant liver dysfunction, we can use DHAP, for example. We have given etoposide at dose reductions with bilirubins in the 200s that we're pretty convinced that they do have HLH, and they've responded very well. And all the patients that have been malignancy-driven, particularly lymphoma patients, anecdotally, of course, with the numbers that we have, but they've done very well, and their HLH has been controllable, and we've got them cured of their underlying lymphoma. So, to come on and borrow from the adult side and give you a little bit of the data of us trying to get our hands around really what does HLH represent in the adult population and the adolescent population. A case review of patients at UCLH and the Royal Free was undertaken, and because we wanted a discriminator trying to find a way of, are we finding the patients, the team looked at patients with a ferritin over 10,000 and then did a case review of all of those patients to see were their features consistent with HLH. There were 137 patients identified. 70 patients have got a complete data set. Of the specialities seeing those patients, 67% were seen by the haematology team, 14% by rheumatology, and 13 others, so immunology and infectious diseases. HLH was considered as a diagnosis in 45, 90% and 46 of those three speciality groups, and a clinical diagnosis that the teams felt that HLH was a diagnosis was made in 37, 60 and 23. If you then apply the HLH 2004 criteria, 33% meet the criteria for a diagnosis of HLH, and there was no difference between the specialities. Steroids and cyclosporin were the mainstay of treatment, more cyclosporin used in the rheumatology patients than in haematology patients. Etoposide used in 73% of haematology patients, none of the other groups. Anakinra was only used in one heme patient and one rheumatology patient. Yeah, and so that I was going to come on to the fact that is changing, but yes, so this is the look back. Quite strikingly, 67% of haematology patients that were in this criteria died during that stay. 10% of rheumatology patients, and so we don't think that rheumatologists are much better at looking after these patients than haematology. Obviously there's some difference in treatment, but what we're hypothesising is obviously the underlying drivers are key to the phenotype and the clinical course that these patients are experiencing, and a lot of these haematology patients are going to have lymphoma driving their HLH, but still that is quite a significant mortality even in patients with lymphoma driving their HLH. So looking at other data to see if people see other things, I thought it was interesting, this series, this is in paediatric patients published in Blood from Texas Children's Hospital, and they looked at just over 100 paediatric patients, and they see a similar pattern in terms of overall outcomes, that autoimmune sort of rheumatology patients, the outcomes seem better than if you've got a malignancy-driven HLH. And so that seems to mirror what we're finding and what we've experienced in our population. Obviously, those were not all HLH patients, they were just patients with a high ferritin, so it's not completely transferable, but I thought that was an interesting pattern to observe. And what they did is they went on and did whole exome sequencing of their patients, and they found a number of abnormalities that are the standard primary HLH genetic lesions that we've been talking about and we've heard about, but also they found other lesions that they thought potentially were relevant clinically that relate to dysregulation of immune response and impaired handling of virus. And so they put forward a paradigm that HLH should be conceptualized as a critical illness phenotype driven by toxic activation of immune cells from different underlying mechanisms. And I wonder, it'd be really interested, we don't have the money, but it'd be really interesting to have a look in the adult population and systematically look at the genetics and see if we are seeing a different pattern. Are we seeing more of these subtle, do you need compound heterozygotes of these different genetic lesions to tip patients into getting HLH, and is that's why they're happening later, or with different drivers being responsible? So this is part of our questions that we don't have the answers to. We know that we are, or we feel we're heading in the right way in terms of developing the MDT, so collaborating with anybody who wants to in terms on the paediatric side nationally, so Hammersmith, Sheffield, but locally I think it's working well in terms of the MDT. We are talking through cases and really just getting discussion, I think, is really the primary thing we want to achieve by doing that. We want to start a local registry. Anakinra is now available and we can use that at UCLH, which isn't the case in a number of different centres from an adult point of view. We want to keep a registry of those patients that are receiving Anakinra when we think it's appropriate. And it'd be great if that evolves into something that's more national. There's still not complete agreement on what data sets we should be capturing for these patients, and so should we use the HLH 2004 criteria? You know, when we were talking last night, people want to look at hearts, echoes, troponins, and capturing a lot of end organ potential dysfunction, and so that's something that we need to nail down. And really, the ongoing debate from the sort of rheumatology, hematology side is Anakinra. When do you use Anakinra? When do you use etoposide? We think potentially that in the hematology patients that etoposide is treating probably some lymphoma, whilst, you know, in a number of patients, whilst we don't necessarily find it, if it's there and patients are not responding, are we missing lymphoma? We had a case of an intravascular diffuse large B-cell lymphoma, which was very hard to pin down the other day, that was driving the HLH, and so whereas the rheumatology team would not want to use etoposide as seen by the audit, that's something that I think from a haematology side we'd feel that we're potentially missing out on in a patient that's not responding. And then ultimately it would be great to have a trial, and then do you have Anakinra up front with steroids, or steroids versus steroids and Anakinra, and those are not responding that we think are moving in the wrong direction, do they then have etoposide? You know, this is all up for debate and things that are part of the ongoing discussions. And then, as I've alluded to before, when do you stop looking at the genetics and the immunology of these patients? How old do they have to get before that's not something we're going to standardly do? There's a cost consideration, but obviously, as can be said, there are patients in their 70s who they're finding relevant genetic lesions in. And so that's the majority of what I wanted to say to you. If I've got enough time, then I can tell you about the indications, or we can come back at later on.
If you want to do just like...
Yeah, carry on. Yeah, okay. So as you probably have heard, that primary immunodeficiencies have been looked at by an urgent policy statement with NHS England, and so various categories of primary immunodeficiencies are now commissioned for transplant in the adult population, which wasn't routinely the case before. We had to do individual funding requests if we want to take some of these patients to transplant. And so in terms of the relevant commissioning for HLH, this is the wording and the pathway, is that if these patients are at risk of imminent life-threatening or irreversible harm without transplant, then they can be considered for transplant, that they should meet the diagnostic criteria for secondary HLH as a result of an underlying immunodeficiency, or if there is no clear underlying genetic cause, then that they need to that there is recurrence of, or that high risk of recurrence of HLH is the other way that you can get out if you've not found a clear underlying genetic reason for their HLH, or that they're refractory or have relapsed post initial treatment. And then the two centres that are going to be treating these patients the majority of the time is UCLH in Newcastle. There's an MDT that needs to agree to the transplant and really looking at the criteria from above, and that's constituted of immunologists, haematologists, and also infectious disease doctors, pharmacists, psychologists. There is a very good MDT remit, and basically this group is meant to agree that the patient does need to go ahead with transplant, and if there's anybody that needs to be involved in the room from a particular complication that patient has had, e.g. they've got renal impairment, then they need to be invited along to the MDT. And really from UCLH point of view, I think the first adult patients from an HLH point of view are going to be transplanted over the coming month and the coming year. Okay.
Are there any others and questions for Ben before we go?
Very nice. Great
Thank
stuff. So empirical use of rituximab and the EBV titers, because I presume your EBV assay is on whole blood.
Yeah, I think,
so
yeah.
The EBV, I don't even know what cells EBV is in when it's Hodgkin.
B cell, I mean, it'll be, yeah, well, probably.
Is it? Yeah. Is it?
Not always.
B cells and Ks and Ts, but more
But
Ps.
because also a lot of T cells, you'll find EBV as well. It's just
I suppose in terms of him, that patient, in terms of got histology, we've obviously got, yeah.
In general, principle,
Yeah.
in everyone, because a lot of HLH lab in T cells, and we had an NK case.
No, but also I've seen PTLD that's EBV driven, that's T cell as well, and we treated with rituximab, and that patient's responded. And I suppose we, which is interesting. And so a lot, I mean, alongside reducing immunosuppression, but so you could say that's what it was. But I think thinking back at the kinetics of that, it's difficult to believe that alone was the reason for the resolution in that patient.
The other thing I was going to ask was, because I think anakinra would be great. I'd love to keep with anakinra, because it would, if we control their disease long enough to actually get the diagnostics for their cancer, because that's half the battle. You can't get PET scans, are too ill, you're trying to find the initial biopsy, you'll get HLH, but you won't get tumour, and then you have to wait and repeat, and all this kind of thing, and it might save a lot of toxicity from the patient in order to keep them alive to get diagnostics. And lastly, which actual genuine question is, are you going to, if we sequence people with HLH who've got underlying cancer, are we going to find genes that show susceptibility to cancer, and it accounts for both their cancer and their response, or their abnormal?
Well, I suppose we do as well, because we find they've got an immunodeficiency, and so, yeah.
So you probably will find, or say you will find things in patients almost certainly.
But when they did the gene screen for the paediatric cohort, how did they identify those genes were causative?
Well, so they did. I think they did. They did also. They looked in relatives, and also they had a education set of, I think, quite a big healthy population as well. And so they saw some other. They had some others that came up that were potentially compound heterozygous, but they actually found that a reasonable frequency in a normal population as well. So they did discount those.
Can I just pick up on the anakinra in malignancy? So the haematologists that I work with are very happy that we use anakinra. So we haven't shifted our mortality rates in HLH associated with lymphoma using anakinra even up to doses of 8 milligrams per kilogram. We've recently published a suggested treatment algorithm in the rheumatology journal for anakinra 1 to 8 milligrams for all cause HLH, and I thought originally, great, now we can use anakinra, we'll use it in their group exactly, either to temporise to get to definitive treatment we've had more success by just agreeing, even if we don't know what the lymphoma is. I'm a rheumatologist, so I don't really get blood drugs, but we've given a few patients, including one who turned out to have an intravascular T-cell lymphoma, chemotherapy up front rather than anakinra. So I think I've been disappointed, probably somebody's been using anakinra ahead of the curve. Actually, we don't understand malignancy-associated HLH.
Definitely, and it does seem a more aggressive phenotype as well.
I've had two 16-year-olds with definite primary EBV infection who've been on anatropes and ITU, and anakinra has turned them round, like that. So I think your patient was a primary and has cleared and will never have another problem, I think. But I think it's a bit. I think anakinra's a bit disappointing.
In the malignancy,
So I think we've got to do those genetic studies, because whatever the cytokines are, interleukin-1 blockade is not good enough to keep these people alive.
And so in all comers,
No.
what do they get up front then in terms? So obviously there's a sort of diagnostic phase. Do you try in terms of steroids versus and anakinra?
Yeah, so we differ from London. We use a lot of intravenous immunoglobulin, but that's historical, because I could get IVIG because we had a friendly immunologist who would put it through a proper indication. But now anakinra is much cheaper.
And IVIG is disappearing.
And IVIG is a real problem. Actually, I've managed to persuade Lever, a bit like you guys, to lever anakinra out. So they get, we use methylpred, although I'm happy for it to be suggested we should be using dexamethasone given the incidence of CNS HLH which we're seeing. They used to get IVIG, but they now get anakinra up front, 1 to 8 milligrams, and we usually start 100 milligrams a day. And if the ferritin hasn't shifted, double the next day, double the next day, and double the next day. And I think one of my early problems, I've been treating that way for about 4.5, nearly 5 years now. One of the early issues was we weren't using enough anakinra, and I'm not sure, when we published that review, the reviewers' comments were, we'd initially put in for 1 to 4 milligrams of anakinra, and they said, your doses are not high enough. Probably I don't know who reviewed it, but probably paediatric, where they're using up to 10 milligrams per kilo. So I don't think anakinra is a panacea in that malignant group, but I think we've got to do that.
And that's why I was saying, I think that if you're not moving in the right direction, either known lymphoma or occult lymphoma or other cause that a topside is treating, then it would be good to not hold off too long.
So I think anakinra is safe, and it's really safe in septic patients. I'm not worried about it concurrent infection at all.
Could I say a quick word about diagnostics and outcomes in patients with lymphoproliferative disorders complicated by HLH? So as my colleague at the back of the room mentioned, there's this issue about the dance that we all go through, looking to find what the lymphoma is and then to target treatment for it. And it is laborious, particularly when patients have already had steroid therapy elsewhere and then they're referred in. So we know that the types of lymphomas that drive HLH typically are of a type where there are a small number of driving mutations compared to things like solid tumours. And all of those patients have circulating cell-free DNA. So I personally think that the outcomes are going to improve because treatment will start much earlier, because you'll be able to identify the lymphoma using cell-free DNA rather than PET scan, biopsy, repeat the biopsy when it's non-diagnostic, do the bone marrow once, twice, 3 times. And we know that one of the most important predictors of outcome with any chemotherapy is performance. And the performance score in these patients is always extremely poor. And often they're starting their chemotherapy in ITU. And we know that those patients have extremely poor outcomes. So I think that the diagnostics is a real challenge, and where I see anakinra being especially useful is giving you that window to get everything done and to be in a position to potentially start some proper therapy, not the topicide. Topicide is not proper lymphoma therapy, but to start proper protocol-specific lymphoma therapy for the right lymphoma when the patient has got some kind of physical performance which would enable them to survive the treatment. Because I think a lot of patients succumb to the treatment we give because they're simply not fit enough to have treatment. But I'll predict that cell-free DNA will solve this problem, especially for intravascular lymphoma, if you look at the degree of difficulty of making that diagnosis in the setting and then salvaging a patient, it's almost impossible. Almost impossible.
And can you get that now?
So Roche Diagnostics have purchased the technology to do it, and I think they'll rapidly bring it to market. There are various groups who've got an assay, but the problem is variants of uncertain significance. So what you don't want is to have a very sick patient with a VUS and then start giving treatment without tissue diagnosis, and then find that the patient might be a bit better, but you're never quite sure about whether it was VUS or whether it was a lymphoma-specific mutation. So validation is essential. Stanford have done the validation, and Roche will bring it to market. I think there are people in London who've currently got a panel that they could do, but it's in the experimental field at the moment.
Can I just say one more thing, just cost-wise? Anakinra is about it's £38 per 100 milligrams. So it's really cheap compared to everything else that you might want to give that patient on ITU. And a ferritin in our lab costs £3 to run. And I suspect everybody here can get a ferritin on the day and get 2 ferritins in a day if they want. But don't forget that there are many, many, many hospitals that you can't get a ferritin on the day. And if you can get it, it's not titrated beyond, say, 16,000 or 20,000. So I think we've also got to make sure that whatever messages we give are really easily applicable to non-specialist units. So that's, those are cheap and easy tests, and they're reliable ferritins are reliable biomarker.
Okay,
Okay.
great. Thanks.
Thanks.
So now I'm going to introduce Nicola Cooper, who's an immunohematologist at Hammersmith and Imperial.
Immunologist and immunohematologist. No,
Immuno is obviously more important. So yeah, and so she's done a lot of work in HLH in adults and going to talk to us about the controversies of management and basically
yeah, and I think we've covered most of it already. So
I know you've had
and so this is so Mike Chapman, who's sitting in the audience, put together these cases for us, and the reason for putting these cases together was partly because we just see almost one a year. We are getting more than one a year. And I feel like each time it's a diagnostic conundrum, it's a clinical treatment conundrum. So I've put together some of the very difficult cases to really pull out some of the areas we can do better in, and actually coming towards anakinra as a potential treatment, which I agree with everything everyone said. I think it actually, and obviously we're all doing very similar things, and actually I think perhaps from the end of this meeting, actually doing a prospective study is what we really need to be doing. So we're all using the same treatment algorithm, and actually we can really properly look at outcome from that point of view. Because I think catching things early is what's really important, and making the diagnosis is really important. So you've seen all of these studies kind of already about the diagnosis of HLH, and I think one of the things Mike was had put together is actually it's quite difficult making this diagnosis, and you have all these different points, but how practical is that really in a DGH or even in a sort of hospital where we don't have genetics or functional testing. The HLH 2004 was designed for children, and I think our patients don't often tolerate that, and one of the things we always do is adapt this, so we don't usually give that high doses of topside, and we try to avoid cyclosporin. I think people tolerate incredibly badly, and Annie was talking about the children who get high doses of steroids, and adults really don't do very well with high doses of steroids. And I think there is a huge problem with missing a diagnosis if we start treatment too early, but there's a huge problem with missing a treatment option if we start things too late. And certainly as an adult physician, I think one of the really difficult things is when to use etoposide. When you've got this really sick patient where you're trying to make a diagnosis of infection or lymphoma, at what point do you start using a chemotherapy agent? And it's definitely a big argument we have with renal physicians as well. A lot of our patients come through the renal team. They hate etoposide, they like lots of steroids, and they like methylpred rather than dexamethasone. So there is always a big discussion around the adults who present with HLH. So this is one of our cases. These are over quite a number of years, and I think we do have new treatment options for this. Is one patient who's presented at the age of 68 The sudden onset seropositive rheumatoid arthritis was started on methotrexate. 4 months later became unwell with fevers and weight loss. And we eventually diagnosed after 2 bone marrows HLH, and he was treated with full HLH treatment. He did very, very well. And he was fairly stable on cyclosporin, but actually it was quite difficult to get his cyclosporin level correct. And he had a sudden relapse and died quite quickly of respiratory failure. And the reason for bringing this case up is this is before we're using anakinra, and actually these patients do die very quickly of this cardiovascular or respiratory arrest. And it's certainly something I've learnt from Taryn, our rheumatologist, who's very keen on using treatment very quickly for these patients. This second patient, I think I won't go into, I'll go through this third case. It was really important because this was a huge delay in diagnosis. He's a 45-year-old Nigerian gentleman who presented with a 2-month history of weight loss, fevers, malaise, and spent a lot of time trying to diagnose TB or trying to diagnose infection, and eventually came into the infectious diseases team with a very high ferritin and incredibly high EBV titers. And we did treat him with rituximab, ganciclovir, IVIG, and we gave him etoposide because of the paper suggesting how important it is to use etoposide very early on. He did get better quickly, but actually became unwell again about 2 to 3 months after we diagnosed him and treated him. And he had CD8 positive T-cell EBV driven lymphoma. Well, it wasn't lymphoma because it wasn't clonal, but I think that gets to your point of where is the EBV from. And it's great if it's just in your B cells and you can deplete that with rituximab, but actually I think it is really important to make this diagnosis. And I think this was on his second bone marrow. So I think one of the other things we've learned is repeated bone marrows is really important in patients who are not getting better to really make the diagnosis. That's really crucial. And I think it's one of the things we have to teach with the registrars as well, is actually just because one bone marrow doesn't show the disease, a second bone marrow, sometimes even a third bone marrow is really important. And Chris, I like the idea of having a diagnostic DNA free blood is incredibly important. And our most recent patient, who I haven't shown here, he had a T-cell lymphoma that wasn't diagnosed in the first bone marrow. The PET scan was negative, and it was only 3 months later with the bone marrow. And I'd already had a big discussion with the infectious diseases saying it must be TB, but it wasn't TB. So I think it's quite difficult to diagnose. This was a patient who had a history of Hodgkin's disease, and his relapse with his Hodgkin's disease 13 years after his Hodgkin's was with HLH. And the reason for bringing this case up is that we treated him directly with gemcitabine. So for him, I think if someone has had Hodgkin's lymphoma before, even if it's 13 years later, you have to think about lymphoma. It has to be the primary cause for that HLH, and you really have to look very hard for it. And actually, it's incredibly important to treat with the right dose. And I think that's a point you've made, Chris, as well. Not etoposide, and actually gemcitabine is much more important for this patient. It was a treatment we wanted to give with the EBV-driven T-cell related one, but he died before we were able to give that treatment. This next case shows the importance of thinking of the diagnosis. This is a Nepalese gentleman, well, a UK-born gentleman who was 42. He presented with very high fevers, deranged LFTs, triglycerides, diagnosed with HLH, no response to infection, anti-infective treatment. They go through huge numbers of treatments, diagnosis before making a diagnosis. There was no evidence of lymphoma, no evidence of TB, but no cultures were taken. The IGRA assay was negative. He had genetic screening, he had all sorts of treatment. He had TB treatment was started together with empirical anti-TB treatment at the start when he was first started on HLH treatment. But he had hepatorenal syndrome and the TB treatment was stopped because there was no evidence of TB in this gentleman. He had no response to HLH 2004. He had alemtuzumab and cyclosporin with an initial improvement of fevers and cytopenias. We were contemplating transplant for him. He was readmitted with fevers, myalgia, and at this point had chest imaging with new onset ground glass shadowing, bilateral cavitating pulmonary nodules, A bowel was sent, but he also had some granulomas in his bone marrow. We started TB treatment before getting any of his TB results back. And I reviewed him on a Friday evening, and I didn't know that he would make the weekend. We started TB treatment Friday. Saturday, he sat up in bed and asked to go home. So I think actually making this diagnosis is really important, looking for TB and actually potentially using TB treatment if you're thinking about high-dose immunosuppression. And I have this argument with the infectious diseases team as well, but TB is actually treatable. And so giving someone a toposid and steroids, if you haven't excluded TB, can cause people to die. Whereas actually giving them TB treatment to cover that period while you're trying to look for the diagnosis, I think is really important.
And they were resistant to doing that.
Sorry?
They were resistant.
Well, the last conversation I had, actually I was wrong in my diagnosis, but the last conversation I had about a patient with HLH who ended up having a lymphoma, but it was very difficult to find. It was a T-cell driven lymphoma. It was a long time, it was hidden for the first few biopsies. And I thought it was appropriate to give him TB treatment while we were looking for all of the other investigative treatments. And the infectious diseases person told me TB is really rare in HLH. And makes you realise that actually because we're not publishing lots of cases, people think that it's really rare. And actually we have to publish the cases which we get wrong and the cases where we miss things, because actually that's where you learn, and that's really important. And I think that's what we sometimes sort of fail to do, I think. I think this is the last one I'm going to do. So this is a 52-year-old gentleman who presented with headaches, myalgia, vomiting, a pre-syncopal episode, fevers. He required he had renal failure, required ITU for hemofiltration. He was fully investigated for HLH and infections. And he was started on anakinra fairly early on in the treatment history. He was a private patient. And there was a concern about whether he had lymphoma driving the HLH. And so we were able to withhold glucocorticoids because the interleukin-1 receptor worked really well. So within 24 hours, it was a dramatic improvement. After 3 days further, he was off inotropic support and came off hemofiltration, and the ferritin normalised. And he was diagnosed with a B-cell lymphoma. And what's really important about this case is we avoided giving the steroids while we're looking for treatment. So I think that's where anakinra has become really useful, and I see that you're saying there are cases where it hasn't been useful, but it can be very useful, and perhaps this patient wasn't quite so sick. But I think for those patients, you're giving them a window of time. And it's something I've learned from Taryn, who's our rheumatologist who's just started this year, about the importance of using it quickly. And actually, it gives you a window of time to try to make your diagnosis better. Final patient this was a patient who was referred to us with a query HLH. She didn't have HLH, but she did have other fever-like syndromes. She had a massive spleen, cytopenias, lymphadenopathy. She had a colitis, and what we established was really a primary immune deficiency that she's had for some time. And the reason for bringing this one up is that we did whole genome sequencing on her and her patients and identified a mutation in BAC2, which we have worked up, and just a single point mutation in one of her BAC2 genes created a missense protein which stops that from being produced. She's heterozygous for that, and that's created an immune dysfunction, dysregulation. And the reason for bringing that up is just to say, actually, it is an opportunity to understand biology a lot better when we have these incredibly sick patients coming through, and I think that's something we really need to do. So, HLH is caused by many different pathologies in adults related to cytokine storm, and actually investigating a cause is what's really crucial. Repeated bone marrow biopsies might be needed, and I think that's really crucial, and we've seen that repeatedly, that patients, and I think actually it's an important thing for junior doctors to recognise that just because a bone marrow was normal at one stage, often it needs to be repeated. culture for TB, and I think doing a bone marrow without culturing for TB, and once you're going in there, I think getting that TB is really, really important. The aggregate is not often helpful. And the other thing I've noticed as well is sometimes when you ask for CMV or EBV, their juniors often do serology. And so you miss another week thinking that the EBV or CMV has been sent, and it hasn't. They've just checked for serology. And actually you need to do the PCR, and actually reminding them that doing a PCR, which again is why we need guidelines for people to sort of try and look at. And always think about lymphoma and TB. So we need to aim to treat the underlying cause. I think 2004 is not great, but we haven't got good alternatives currently. I learned that etoposide is really important. I was quite reluctant to use etoposide. I think we do need something to replace etoposide, but at least it does give you a window. We've had some good experience. We've used anakinra 4 or 5 times in the last year. We seem to have suddenly lots of HLH patients, particularly stopping this sort of, and I think that some of the deaths that we've had have been sudden cardiac arrest, sudden respiratory arrest, which we can't explain. And I think that's what you're trying sort of to terminate, particularly in these older people who can be quite unwell. Excuse me, we've had quite a lot of discussion about the diagnosis. So, and I think actually if we can, creating guidelines, important to give criteria for general clinicians to be suspicious. So refractory fevers, and doing a ferritin or splenomegaly, unexplained cytopenias. It's really important to trigger the general physicians to think about HLH. And once you've thought about HLH, doing the rest of the screens, obviously triglycerides, we love doing that, ferritin, coagulation, LDH, LFTs, liver function tests are really important. And I think that partly depends where you come from. I know Dr. Layton, Mark Layton, who really started up the HLH practice in the Hammersmith, came from King's, where a lot of his patients came through the liver unit. Our patients tend to come through the renal unit or the lupus kind of unit. So HLH patients are a different flavour depending on where you are. And I think what's important is making sure you are looking for the diagnosis. So bone marrow aspirates, bone marrow cultures, MRI, the head of those neurological function problems. Soluble CD25, I agree completely with Kimberly, it's totally unhelpful in making a diagnosis. And I suspect sometimes we say, I think sometimes people go, oh, send off the soluble CD25 so you can have a think about the diagnosis while you're waiting for it to come back. In some ways it's delaying your having to make a decision on it. Whether it's useful as I think you had to probably have the soluble CD25 in your own lab for it to be useful tracking, and I think ferritin is pretty good, actually. We've never had use for NK cell function assay. I'm curious to know, Kimberly, if you think the 107A expression is useful.
Well, it's very good at screening for the FLH345, Graceli, Shediacs, new gene that Tom has. I think it's very useful for that. We do NK killing assays. We're only doing them in patients who get VUSs off of a genetic panel.
It's not useful, is it?
If they're really pathogenic or not. There's no point in it because if they have normal perforin and a normal bra, they're going to have normal perforin. It's useful for clarifying some rare genetic variants.
Because this comes up in all of the guidelines reviews, and I don't think it's a helpful thing
for
most people to do.
And I have self-interest. I helped with that paper, but there's a paper that we put out in Blood about 2012 that looked at roughly 500 cases throughout Europe, and basically no one's, the big centers are not doing NK killing except on a very precise
so you need to know what you're doing.
Patients. But you do need to know how to do the assay.
Okay, cool. And genetic testing. And I guess that will continue to change over time. Then looking for a trigger, and I think PCR testing for viruses is really crucial, and we've had an HHV8 related HLH, EBV, CMV, HSV1, so I think all of those are really important. Autoimmune screen, obviously, scanning. So someone was asking whether you should just routinely do a PET scan. I guess I put that out to the audience of whether a PET scan should be done if we don't know what the diagnosis is, and obviously thinking about all of the unusual treatments. And I remember I've spent many a weekend trying to look for leishmania on bone marrows in patients. And then Mike put this together as it's complicated, but it is complicated. And how can we try to manage patients better? And I think Mike did a really good job. Everyone's taking photos up for you. The point in adult ITP, if you know what the trigger is, it's likely to be short-lived. You may just be able to treat the known triggers. If the patient's unstable, you may need to use etoposide, high-dose dexamethasone or anakinra. If you have a known trigger, but it might be a prolonged response to treatment, although you're treating the unknown triggers, you may also need HLH-directed treatment. And if you've got no known trigger, using HLH treatment, but actually continuing to look for a diagnosis is what's really important. Once HLH protocol is initiated, reviewed over 2 weeks. If refractory disease, consider experimental treatment. Refractory, consider transplant. And we have not transplanted any HLH patients at the Hammersmith, not that I remember of, anyway. And I think, Mike, you also just did a really good job of looking at all of the literature, and there's just a lot of literature. And we were kind of like racking our brains really to decide, well, what do you do with all of this literature? Where do you go for next? And then Taryn came along with her experience of anakinra. And I think we seem to have heard, there seems to be a kind of like theme coming around here, that it's something we're using a lot early on, and I think it would be good for us to do a prospective study. And I think we do need to have some kind of registry for patients with HLH, a way of collecting both data as well as genetics, and a treatment pathway, which I think anakinra looks a good option to me. And Mike and I discussed a lot a different type of anticytokines, and I think, as has already been discussed, anakinra is a very useful treatment because it doesn't seem to mask infections, doesn't seem to cause infections, and it can be stopped really quickly. And that's the other thing Taryn really introduced us to, is that if someone's getting worse, you can actually just stop it 12 hours later, it's out of the system. So it's not switching anything off that can't be just replaced. And I think the other thing that we have developed, so we have an immune hematology MDT once a month, and we have created an HLA MAC team. Taryn's been really important in trying to get this to happen. Previous to that, it was very difficult for us to work with a lot of different colleagues. And so we have infectious diseases, rheumatology, renal, and I think respiratory TB is really important to just think about whether you should be using TB. Now, we've not yet been able to properly bring that into a guideline, but I think thinking about treatment for that while you're immunosuppressing people and looking for disease cause is important. That's it. Thank you.
Are there any questions before we move on? I think we've had quite a lot of discussion along the way, so it's been answered.
PET scan.
But go on.
That acutely, would it not?
Well, that's what I assumed. Yeah.
It's
Yeah.
not hot everywhere, actually. It isn't. It's easier to get a PET scan at UCH than a chest X-ray. I kid you not. So yeah, you basically walk in the front door with a fever and you get a PET. So it does not light everything up, and it lists a multitude of sins. But I don't think, not that they would then be picked up by a CT. I think it should be part of I think it should be part of that initial data collection myself.
Just a comment about getting people who have lymphoma and who get steroids prior to a definitive diagnosis. I think the lymph nodes disappear very quickly, but extranodal disease, which a lot of patients will have who've got HLH, will still be hot on the PET. So it then alerts you to the fact that you've got something that you could hit with a needle even though there's no detectable lymphadenopathy that you would see on, for example, CT. So I personally think that prior to the era of molecular diagnostics for lymphoma, doing a PET is absolutely essential, especially in those people who've been pre-treated with corticosteroids prior to the definitive lymphoma diagnosis.
And that's relevant for we have a lot of post-renal transplant patients who get odd cytopenias and things. So again, it's relevant for that cohort, and that's an extension of the same disease. It's just smaller, I think. So perhaps we're actually a working party to create.
So there is one, and you're coming.
Oh, lovely. Cool. Okay, thanks. Okay, great.
Okay.
And one final point is that the registry that I've just submitted to IRAS deliberately left histocytosis as everything beginning with H. So it would, you don't actually need ethics to obviously collect patients alleged and all that kind of stuff. But it does allow you to transfer samples around the country.
Yeah.
I think so.
And is it NIHR badged?
Yes.
Great. So
it would, yes. It would.
Okay.
So it's just a UK histocytosis registry, and you could, and it's going to be based on the red cap and all that stuff.
Excellent.
So
yeah.
So
we're all replicating, doing similar
if
things.
there's a need to do adult, I think paediatric you already saw.
We're going to jump on autism.
But
Yeah, but rather than having all of us do little bits.
Yeah, absolutely.
So what you're
Yeah.
saying, you could extrapolate that to adult.
It's
Yours
all
is-
ages, it's got all ages of group, and it's all histocytosis. So you might have to then design your own data elements.
Yeah.
What you have to put a consent form and stuff would be, when the ethics would be done in a way.
Sounds good.
And it's only taken about 2 years.
Yeah.
So nicely leading on to the importance of registries is the late effects of transplant, post-transplant for HLH, which despite the agenda makes it look like, but Kanchan and Annie are not sisters or related anyway. So I think Kanchan is one of our transplanters at Great Ormond Street Hospital, and Annie, who you've heard already, is one of the haematologists. And so they've done quite extensive studies on the long-term effects post-transplant of patients with HLH.
How do I move this slide?
So I think it should work with this one. Yeah, so backwards and forwards, and then you've got a pointer if you want to.
Yeah, cool. Well, now we decided who to transplant and how to transplant, just talking about what happens after transplant and whether everything is okay. So in pediatrics, we're always interested about the late effects of transplanting children. And so this is what this proposed study is about. And supported by a grant from Histio UK, which we got last year for £25,000. I'll talk a little bit about that. Thank you, Histio UK, before we start. So background, Austin said that compared to other diseases, we haven't seen a great improvement in survival after transplant for HLH because of the various difficulties of who to transplant, when and how, but it has sort of improved a little bit over the years, especially since we're using reduced intensity conditioning rather than myeloablative conditioning. But as these children are surviving 10, 15 years post-transplant, we're seeing some late effects. Some of it has been well recognized and published, such as the neurological late effects. But there are non-neurological late effects variably reported in every organ system, though not systematically studied. So late effects can be any and every organ. In HLH, the non-neurological late effects have caused concern among physicians who are seeing them in late effects clinics. There's a feeling that these late effects are more than what you would expect for another transplanted population with reduced intensity conditioning. Beyond what has been published, for example, with MONK18-2 and ongoing gut issues, well-recognized syntaxin deficiency and a higher incidence of secondary malignancy. But beyond that, obviously, we thought it's important for counseling families, for alerting physicians in late effects cancer as to what they should be looking out for, and for patient selection to study this in a systematic manner. Anu?
Yeah. Okay. So I have an interest in post-transplant late effects, and I think whenever we counsel families for a transplant, as parents, the questions they would obviously ask is, what are the chances of surviving it? And then once we survive it, what is the future going to look like? Most importantly, and those kind of questions are addressed by this circle over here, because a lot of it depends on what the pre-transplant toxicities are and what the children have picked up as a part of their pre-transplant toxicity, steroid toxicities, viral reactivations, etc. Then the question is about conditioning protocols, and as Austin has very clearly shown in the survival curves, that reduced intensity transplants is certainly the way forward because you get better overall survivals, and getting the right level of mixed chimerism is important. And then obviously the post-BMT sequelae about GVHD and what the chances are of acute versus chronic GVHD. So when we counsel families, and I think Kanchan, you do a lot of that in the pre-transplant clinic, when you're counseling families, it's all about what is the future going to look like. Now, when I receive them in the late effects clinic, that's where all the story plays out. And I can say that most of our patients in late effects clinic don't seem to have lots of toxicities with exposure to steroids, because it's a short, sharp burst of steroids. So they're not running around with weakened bones, osteoporosis, osteopenia, and that sort of thing. So we're not seeing that side of things. Again, chemotherapy, the chances of late second malignancies, because there's a lot in the story in the literature about etoposide and exposure to etoposide causing second malignant neoplasms, and that's what parents are often worried about. You're dealing with a non-malignant disease, and yet you're saying you might get a cancer later on, and what's the chances of that? We don't see that. The literature is written fairly expansively. There's some anecdotal evidence, but not a lot. And then GVHD, so fortunately for us, at least from our Great Ormond Street cohort, we haven't seen children with chronic GVHD. There might have been some acute GVHD. So we have a very systems-wise approach, start from the top, go down to the toe, and work every system one by one to see what else is there. And that's fundamentally a late effects approach for any transplant phenomenon. But the thing that I think that we both are talking about with this study is looking at genetic HLH, and if there is a phenotype-genotype correlation for the late effects post-transplant. Are we beginning to see other constitutional effects of having those germline mutations, homozygous, compound heterozygous, whatever those mutations are? Are there other specific disease-related late effects that we need to look out for? And that is two areas that I've found in my endocrine late effects, which I run with an endocrinologist, that we've begun to see, and I think Britta Janker, who's published a lot of data on HLH, there's not a lot out there in the literature, but there's the conversations you have in meetings. They tend to be small, they're short. They're running at the lower end of their target genetic centile range, or just a little bit below that. When you do formal growth hormone assays, and there are several of them, as Vasanta will know, none of those growth hormone assays actually come up with an abnormal production of growth hormone. But these children are quite small, quite distinctly from their siblings who are well on the 50th or the upper end of the target genetics, and you end up with a short child. It's not because of steroids, because you think obviously steroid exposure, short child, but it isn't that. So I think what we would like to prospectively do as a part of your study is to look at parental heights, genetic target range, limb length discrepancies, most importantly iron overload. We tend to forget that a lot of our patients have transfusions during treatment, as a part of post-transplant or during transplant. We don't know how much of the iron overload is contributing to that growth deficiency, but in that case you might be a growth hormone deficient. The second area is puberty and fertility. Because remember, the whole point of reduced intensity transplants is to reduce the toxicity and the TRM acutely as well as chronically. And the things that we absolutely hone down on is, are we talking about a constitutional delay in puberty here? Are we talking about compensated hypogonadism, which is what we see? So what these patients have is high FSH or high LH, boy-girl variations, but essentially reasonable levels of estrogen and testosterone to take them through puberty. But what you might expect is during their 20s, when it's sort of time to have babies, for the girls or for men to father children, you might begin to see testosterone failure, you might begin to see estrogen failure. And then it all becomes a question of what's that critical time window where if you've got to have babies, have them quick kind of phenomenon that we talk about. There is no guidance on this, but it's a process of discovery that we're doing, which is what proportion of these patients, what's the time to elevation of FSH, what's the time to elevation of LH, and is there a window that you would say, well, probably this is the sort of time that your fertility is potentially preserved. But anyway, these are the things that we're looking at. And so, I mean, this is all about what's already in the literature, talking about growth, thyroid dysfunction, vitamin D deficiency, gonadal function, fertility, very transplant-related RIC versus MAC phenomena that you see. But what we're trying to do is, in genetic HLH post-transplant, there is a growth pattern story here that we need to investigate further. And it might be related to looking at imaging the pituitary, because I know in LCH, which is the other disease, you do tend to see growth issues in them. There might be something to link it. We don't know that as yet. Lastly, and most importantly, is about CNS HLH. Now, this is really important because in our experience, for children with primary or genetic HLH, and sometimes in the literature, even acquired or secondary HLH, we can get patients who have the obvious classical symptoms that we were talking about, which is CNS involvement, but sometimes you get a normal CSF, but neuroimaging that may be abnormal. So you can get every permutation and combination that you can with CNS HLH. You also get patients who have got excellent systemic control, but the CNS disease takes off and it reactivates whilst you're de-escalating treatment. So lots of things can happen. We are now, at least when I was training as a registrar, we never did MRIs for our patients. We almost virtually didn't do CSFs because the low fibrinogen, the coagulopathic, and you're thinking you're not going to go into the needle into the back if you've got prolonged clotting, so you wouldn't do it. But I think now, as soon as we have a window of opportunity, we do want a baseline MRI, we do want a baseline CSF, and we do want to watch for signs of CNS disease reactivation. Once the disease systemically is under control, you might get CNS disease reactivation. So this is the sort of kind of algorithmic approach. It's not super clever, it's just sort of saying, look out for it, give steroids, give etoposide, and if you're really concerned and it's not making a difference, give intrathecal methotrexate, which is what we do. And this was a paper that Kanchan published in Immunology and Allergy. It's probably the only paper that I could find in PubMed which looked at the cognitive and psychosocial effects post-transplant, and that's fundamentally the bottom line, which is we are seeing not all children, but some children where you may have identified CNS HLH at diagnosis or during treatment, or actually you never thought about it. It wasn't a problem at all. But when you look at them in the post-transplant phenomenon, they do have levels of lower intellectual functioning. So when I see my patients in the late effects clinic, apart from saying, how are you, how's your gut, how's everything else, I ask about academic performance in school, what's happening, what are their metrics in school, how much of support are they needing. And you begin to then slowly glean out that there is some CNS inflammation that may be identifiable or not, but which is playing out in the post-transplant phase. The question is how much of immune reconstitution, mixed chimerism that you do with a transplant actually affects what's going on over here. I just don't know about that. But this is the three areas that I look at when I see my patients are growth, puberty, fertility, and neurocognition.
Okay. So obviously there are lots and lots of studies and publications about late effects after transplant, but when we met in Dublin for the Histiocyte Society conference, several members of the group expressed concerns about the pattern of late effects that they were seeing in their HLH patients. So extreme short stature, for example, severe hearing loss in a proportion of patients, bony deformities, and everybody said that this is out of proportion to what they would expect in another transplant setting. So we decided it would be worth systematically studying these late effects after specifically after HLH transplant, and we were fortunate to get a small grant application successfully through Histio UK of £25,000. In such a rare disease, we decided collaborating with the American Bone Marrow Transplant Registry would maximize our data, and Scott Baker is very active in the Histiocyte Society group, and there's a precedence of other studies with the European Bone Marrow Transplant Registry and CIBMTR, so we thought we would do it in this manner. The inclusion criteria are pediatric aged patients transplanted in the era of genetic diagnosis, mostly surviving at least 2 years post-transplant with an adequate follow-up, and we estimated that the sample size of available data sets would be about 350 patients. Then we had to develop a questionnaire, which was a really mammoth task because we are looking at every organ system potentially, but we can't ask people to fill in lots and lots of questionnaires, otherwise we won't get anything back. So we designed sort of drop-down menus about very important things, and people just click on them. For example, hearing loss is just going to be mild, needs hearing aids or doesn't need hearing aids, that kind of very functional data. Similarly, schooling, special school, additional help at school, that kind of thing, which we expect will have more compliance than more complicated data sets. Then we ran, one of our fellows ran a test set on the questionnaire and pointed out areas of difficulty and things that we'd missed, and we further modified the questionnaire. So where we are at, these have all been ratified and ready to be sent out. The statistical analysis will be done by EBMT of the combined data set from Europe and America. So how are we going to use the grant money? So we thought again long and hard about this, and finally we decided that we'd remunerate centers for per patient of completed data set. And they are free to use the money as they wish. They may give it to a medical student who's collecting the data, additionally to their data manager, or however they want, because the rules and regulations around this were very complex in each country. So anytime now the questionnaires are going to be sent out to the centers. We presented this at the Inborn Errors Working Party in Leiden. There was enthusiasm and agreement that we need, it's an important thing to look at, and hopefully in a year I'll be coming and telling you what we found from this important study. And obviously a lot of people involved in this, from EBMT, CIBMTR, and the Histiocyte Society and Histio UK for, it seems like a small amount of money, but it is some incentive for people to do. They might have to bring patients back into their late effects clinic to do these testing, etc. It's some incentive for them to complete this study. Thank you.
Great, thanks for the double act. Any questions on this presentation?
Silence. Tired.
Sorry, can I just ask about the endocrine testing? I'm not sure which.
Yeah.
About, sorry,
So the endocrine testing that you do in your late effects clinic. So do you do inhibin B or?
Yeah. We do AMHSN and inhibin B, but the question is, I think we're just collecting the data.
Sure.
The PanCare are looking at all the data, so it's all going into, but it's going under the umbrella of reduced intensity transplant. So myeloablative versus reduced intensity, and all that data is being collected.
I do that too. I have no idea how to interpret.
Exactly. There are all the ranges that come that are reported, but the point is when you actually look at, if you look at the curve on all the dots, and actually if you look at the variation, it's massive. So you can have people, and the thing is people really don't know the role of this in pre-pubertal children. So I think it has more relevance in a post-pubertal childbearing or cohort. But I think but we're just trying to see if there's a trajectory that we can identify, collect the pediatric data, extrapolate it to what adults are seeing, and then see other trends that we're seeing.
And do you think there's any role for egg preservation?
Angela, over to you.
So,
Egg preservation.
Egg preservation. So, obviously, most of our patients with HLH are very young, and almost all are prepubertal. So, egg preservations.
If they're coming towards the end of puberty, or coming towards puberty, or, you know, as you said.
But you're on.
Yeah.
We're kind of offering it, isn't it?
So I guess the damage is already done by then, if it's to be done. So there's experimental ovarian cryopreservation, which in the south of England is being offered by Oxford, and Royal Free are about to start offering it, I think. So it's entirely experimental. I'm aware of one thalassemia girl who's had a successful baby from a prepubertal ovarian cryopreserved tissue. Not aware of any other babies being born from prepubertal ovaries, but this service is available. And the rest of Europe are doing it, and we are also doing it with appropriate consent, and finding that a lot of families want to take it up. So it's very, very clear. It is not known what developments in technology might lead to in 20 years' time, but as of now, no proof that it may work.
And you're right, so there are two windows to look at fertility. One is the most obvious one, which is before you do the damage. The thing is, once the gonadotrophic exposure has been done, and there is an episode where a child has gone into spontaneous puberty, spontaneous menarche, or, you know, Tanner stage progression, males progressing without any effect on testicular volumes, and if all is there. Previously, I can tell you, when we sent this to the experts, they'd come around and say, you've done the damage, there's very little chance. However, the door is opening. There are people, there's a team at UCLH who are interested and are willing to accept referrals for boys and girls. For boys, it's harder because it's about trying to get hold of sperm and the age and the psychology behind it. Because sometimes you can just think, well, it's easier to get. But the issue is that a lot of these children who are going there at the age of maybe 13 or 14, coming away with you can't father children, affects a 13-year-old far more than you think it would. So there is a whole bunch of other stuff that we have to deal with. We can't just say, oh, can you go there and, you know, have this boy produce some sperm and see if he's azoospermic or if he has some, and that sort of thing. And even the biopsy side of things is quite a huge psychological burden that they carry. But we do send them, at least for counselling, and then they have an opportunity to say whether they'd like to explore it or not. Previously it was no go. Now it seems to be a yeah, why not, let's think about it. Especially if they're having follicular activity in their ovaries, then you definitely.
Great. That was a fantastic talk and a great end. We started at the beginning with acute and we ended with late effects. I've just got a couple of things to say quickly. I was told by Lynn at the beginning, and I forgot to tell you that if you want to claim your CPD, there's a questionnaire. So they have to send back to you, and then you give them a certificate. Is that right?
Correct.
Okay. So some kind of deal going on. Great. That's the first thing. I wanted to thank all the speakers, because it's been a really fantastic day. Actually, it's the best forum we've had, and there are two people left in the room that we really need to thank. Lynn for putting on all the organisation, and especially Claire for putting together a great programme.